So I feel like when you're first starting a patient, you think about what is their compelling indication. And so are you choosing the GLP agonist or the SGLT2 inhibitor? But ultimately, most of these patients are going to require additional pharmacotherapy, not just for their glycemic control, but when you start to think about all of the other benefits that we've already talked about today, right? The cardiovascular health, the kidney health, and the liver health, you start to say, why wouldn't I add this on?
Welcome to Medication Talk, the official podcast of TRC Healthcare, home of Pharmacist letter, prescriber insights, and the most trusted clinical resources. Proud to be celebrating 40 years of unbiased evidence and recommendations. On today's episode, listen in as our expert panel discusses which diabetes meds have cardiovascular benefits. We'll review the evidence and discuss the pros and cons of SGLT2 inhibitors and GLP-1 agonists in patients with or at risk for CV disease. Our guests today are Dr. Lauren G. Pamulapati from the Virginia Commonwealth University School of Pharmacy and Dr. Christie Schumacher from the Midwestern University College of Pharmacy. You'll also hear practical advice from TRC's Editorial Advisory Board member, Dr. Stephen Carek from the USC School of Medicine, Greenville. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts and frontline providers discuss and debate challenges in practice, evidence-based practice recommendations, and other topics relevant to our subscribers.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. Please log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses. For the purposes of disclosure, Dr. Schumacher reports a relevant financial relationship as a Speakers Bureau participant with Abbott. The other speakers you'll hear have nothing to disclose. All relevant financial relationships have been mitigated. Now, let's join TRC editor, Dr. Sarah Clockers, and start our discussion.
So to get us started, Christie, could you give us a high-level overview of which diabetes meds can reduce cardiovascular risk?
Yeah, so when we look at the different blood glucose lowering medications, there's really two main classes of drugs right now that have shown benefit reducing cardiovascular risks in their respective cardiovascular outcomes trials. So if we look at the different cardiovascular outcomes trials, they were designed by looking at historically the 3-point MACE, which included non-fatal MI, non-fatal stroke, and then cardiovascular death. So the ones that showed glucose lowering reduction as well as a decrease in cardiovascular death were actually liraglutide from the LEADER trial, semaglutide from the SUSTAIN-6 trial, and then dulaglutide for the REWIND trial. So those are really the 3 GLP-1 receptor agonists that have demonstrated cardiovascular benefit. Exenatide once weekly was neutral in its cardiovascular outcomes trial. And in oral semaglutide's trial, actually we just got the high-level results for it from the SOUL trial, which showed that oral semaglutide did have cardiovascular benefit, but that hasn't been published yet. We only have the high-level data. But we know that potentially maybe oral semaglutide might have benefit as well based on those results. And then for the SGLT2 inhibitors, they've also shown cardiovascular benefit. And those ones that have shown benefit in their cardiovascular outcomes trial were dapagliflozin in the CANVAS program and empagliflozin in the EMPA-REG trial. As far as tirzepatide, I know that's the new one. We know it as Mounjaro is the brand name. We're still waiting on the cardiovascular trial for that one. So the SURPASS cardiovascular outcomes trial is going to look at tirzepatide and compare it to dulaglutide for its cardiovascular outcomes trial. So that one's ongoing. So right now, we still don't know really if tirzepatide reduces cardiovascular risk.
Great, thank you. Lauren, we'll shift to you. Which diabetes meds possibly have cardiovascular risk? We always get a lot of questions about metformin and pioglitazone, and I'm hoping you can enlighten us on their role and their effects on MACE.
Absolutely. Thank you. So metformin obviously has been one of our backbone of therapies for so long. And I think a lot of that obviously comes from the UKPDS trial that showed the reduction in mortality and morbidity in patients who were prescribed metformin. And so I think that's where we're seeing some of that possible benefit that you see with MACE. And then for pioglitazone, really it's being driven by stroke reduction and primarily in recurrent stroke. So in patients who have had a history of stroke or TIA, that's where we're really seeing that benefit that we see in the IRIS and proactive trials. But really we're seeing pioglitazone further down your algorithm when you're thinking about treating your patients with diabetes after you're using an SGLT2 inhibitor or GLP and really trying to prevent recurrent stroke in those patients.
Great, thank you. And then do we have any medications for diabetes that increase cardiovascular risk?
Yeah, so thinking about pioglitazone specifically in TZDs, that increased risk of fluid retention and heart failure. And so we really want to be avoiding any TZDs, pioglitazone being the one that we see often being used nowadays. That's the one we'd really want to be avoiding in patients who have a history of heart failure.
Great, thank you. So, Lauren, how do GLP-1 agonists and SGLT2 inhibitors reduce cardiovascular risk? What's the mechanism behind this benefit? And do they impact inflammation or what are their effects based on what we know today?
Right. I know. Isn't this like the question that I feel like everyone was always trying to dive into when these started coming out and we saw these great benefits? So GLP agonists and the SGLT2 inhibitors are reducing your cardiovascular risk by improving that metabolic control, lowering some blood pressure, but really reducing inflammation and improving endothelial function. And in some cases, really stabilizing those atherosclerotic plaques. And so we think about our GLPs really acting through the anti-inflammatory pathways, where our SGLT2 inhibitors are really impacting our hemodynamics via that urine sodium excretion and reducing that oxidative stress. And so I think that really helps when you're thinking about, when we'll talk about as we continue, like what medications are we reaching for first? Are we reaching for our GLPs with the ASCVD risk and our SGLT2s first for heart failure risk, and thinking mechanistically that really is helping you kind of make sense when you think back to how they're impacting your cardiovascular disease.
Thank you. And then, Christie, can you comment on benefits of GLP-1 agonists on MACE?
Yeah, so when we look at the original cardiovascular outcomes trials, most of the patients in the trial were over the age of 80 and they had a history of cardiovascular disease, chronic kidney disease, and heart failure, or they were a little older over the age of 60 with one or more risk factors for cardiovascular disease. So when we think about the GLP-1 receptor agonists and looking at their MACE benefit with Trulicity or dulaglutide, subcutaneous semaglutide or Ozempic, and in liraglutide, Victoza, these are all people that have had established cardiovascular disease or at high risk for cardiovascular disease. Now, based on the results of the cardiovascular outcomes trials, there's been other trials that have subsequently been done, such as, for example, STEP-PATH-PEF looked at people that just only had obesity without diabetes and the benefit of the GLP-1 receptor agonist, subcutaneous semaglutide, on heart failure preserved ejection fraction. So we're starting to see some different studies come out that are looking at populations of people without diabetes that don't have high cardiovascular risk, and then they're just looking at how these agents work in more healthy individuals, so to speak, without diabetes with high cardiovascular risk.
Thank you. Lauren, are there specific GLP-1 receptor agonists that are more effective for MACE? And is there a best one to reduce risk of MACE?
Yeah, so when we think about MACE for our GLP agonists, the ones that have shown benefit are dulaglutide, semaglutide, specifically the injectable format, and liraglutide. When we look at some of the other trials, so with like tirzepatide, that trial is ongoing, and so we don't really have that evidence, although I would suspect it would be a hard sell to not see that benefit. But when we look at the other ones, exenatide, and when we used to have lixisenatide on the market, those really showed neutral benefit. And so when you're thinking about your patients who have cardiovascular risk, you're really reaching for dulaglutide and semaglutide from a prescribing perspective, really from ease of use as well. Obviously, depending on formulary, as we'll get into, you might be reaching for liraglutide for some of these patients, depending on what they're able to get based on cost and availability. But really, for me in my practice, I'm reaching for dulaglutide and semaglutide.
Thank you. Christie, which diabetes meds reduce risk of heart failure exacerbations?
Yeah, so the SGLT2 inhibitors reduce the risk of heart failure hospitalizations. As many of you know, they're now recommended based on the 2022 ACCHA heart failure guidelines as actually one of the 4 pillars for heart failure reduced ejection fraction therapy. So we really should be initiating SGLT2 inhibitors in people not only with diabetes, but also in people with heart failure without diabetes right away within their recent clinical diagnosis. So they are now first-line therapy for heart failure as well, just based on some of the original data that we've seen from the cardiovascular outcomes trials and subsequent heart failure trials.
Excellent. And then when you say heart failure, can you just describe, are we talking about heart failure with reduced ejection fraction or heart failure with preserved ejection fraction or both?
Yeah, so we're actually talking about both for dapagliflozin or Farxiga and an empagliflozin or Jardiance. So it's been interesting because historically, there really haven't been any medications that have been shown to reduce hospitalizations for heart failure or cardiovascular death in the heart failure preserved ejection fraction population. So here we have 2 medications, dapagliflozin in the liver trial and empagliflozin in the EMPEROR preserved trial that showed a benefit in the preserved ejection fraction population. And then as far as the reduced ejection fraction population, dapagliflozin and empagliflozin as well showed benefit. However, if you look at the cardiovascular outcomes trials, what you see is in the subgroup analyses, looking at heart failure benefit or in the secondary outcomes, you see that they all did show a trend in reducing hospitalizations for heart failure that was statistically significant. So all of the SGLT2 inhibitors did show that heart failure benefit in their cardiovascular outcomes trials. However, with bexigliflozin or Brenzavvy, they actually did not study it. It's not available if you try to look up the data. So that one's a little bit controversial because it is the most affordable SGLT2 inhibitor. So if you did need to use it, I would say you could probably assume a class effect.
Great, thank you. So that's a little bit of the data behind the scenes. And now we're going to transition to what do we do with this data? How do we apply it to our patients? I'm going to pull in Stephen from a prescriber perspective. And how do you decide which med to prescribe first for your patients with diabetes? Can you walk us through your decision-making process?
Yeah, sure. I'll try to cover my high points. And obviously, the goal is to individualize decisions. Is what is going to be best for the patient? What are they going to be able to remain on for the long term for hopefully control over diabetes and definitely reduction in that risk of those cardiac events or exacerbations of their underlying chronic diseases like heart failure. I think the first thing that I'll typically look at, though, is when I see a patient trying to decide to initiate is what's that A1C? The reason is that if they are floridly uncontrolled, like an A1C greater than 10, I'm really going to be pushing for those GLP-1s, maybe a long-acting insulin to help control their hyperglycemia. With things like SGLT2s, I do worry about potentially the diuretic effect that may have for those uncontrolled diabetics. That glucosuria may cause dehydration, electrolyte abnormalities, potentially unmask that euglycemic DKA. We talk about the urinary tract infections as well that cause. So I tend to hold off on initiation of that unless they may have, severe heart failure and already maxed out on other goal-directed medical therapies. But let's say their A1C is somewhere between that 7 to 10 range, in which case we're really going to focus on what are those compelling indications. Are we trying to manage cardiovascular risk factors? Are we trying to manage obesity? Are we trying to manage heart failure? I think this table lays out pretty well which one you may or may not want to choose. In my clinical practice, I'd probably say most of my patients that I see have cardiovascular disease risk factors as well as obesity. And so I tend to start with a GLP-1, but definitely those that have like heart failure, CKD, I'm more likely going to lean towards initiation of an SGLT2 for their management of their type 2 diabetes.
Great. Thanks, Stephen. And are you adding metformin onto these drugs or are you using metformin first?
Oh, that's a really good question too. And I think one that's sort of seeing some evolving practices as well. I mean, it used to be metformin for everyone. I'm slowly starting to, even in my own practice, kind of preserve metformin. I mean, it's so cheap, readily available, kind of minimal side effects for most patients that don't have like chronic kidney disease and at least kind of tolerate some of the initial GI side effects. And I still tend to use it a good bit, especially if their A1Cs are relatively, again, that 7 to 10 range. And there's so many cost barriers for patients that may have GLP-1 or maybe have indications for GLP-1s or SGLT2s. So it's a great cheap medicine, still part of my kind of toolkit for managing diabetes. I think these newer medicines, these GLP-1s, SGLT2 inhibitors, I mean, there's so many benefits, and I think the effect of their benefits is really profound and significant in not only treating diabetes, but preventing these cardiovascular endpoints, that I'm starting to use them without metformin, particularly for those patients that may have the means of getting it affordably, like insurance means, or just have access to it.
Great, thank you. Lauren, do you have any other considerations or thoughts when you're recommending these medications for patients?
I think Stephen really hit some of the high points. I mean, I really think, starting from the top, like where he's talking about metformin and how, there are patients who, when they come into your clinic and you're like, you really need some glucose lowering, and you also look at their past medical history and you see they have a strong cardiovascular history or a strong, you start looking at their labs and you're like, hey, your kidney function is starting to decline, right? So starting to have that conversation with them and say, here's all of our options that we have. Here's the evidence. We could start you on metformin. We're going to get, a pretty decent A1C lowering depending on how far we titrate up that dose. You typically think about every 500 milligrams being about a 0.5% A1C lowering. And so working your way up to potentially getting anywhere from 1 to 2% A1C lowering. So depending on how far away they are from goal. But as I start to see patients who have declining kidney function, I say, well, this is really only helping us with one thing by doing metformin. So why don't we try to see if we can help you also preserve your kidney function and put you on an SGLT2 inhibitor? And so I think in that aspect, you're looking at just your oral options and can be an easy sell for some patients. But what I've really seen a ton of patients coming in is really looking for that weight management with the GLP agonists, and especially when we are looking at our GLP agonists, not just helping with weight and cardiovascular health, but really now the evidence with our kidney function as well. You can really start to say, like, why don't we really focus on 3 things for you, and saying, we're going to really target all 3 of these issues that you have happening without adding on additional medications. And we can do it with just 1 injection a week. So I think that's really how you can start to tailor your conversation with your patients and really start to give them all the options. I think that's the most important, is really laying out, here are all your options, here are the risks and benefits of each, and saying, I often tell them, if you were my parent, this is what I would probably recommend for you at this point. And that tends to really help in trying to relate to your patients and having them understand where you would be. And then with the metabolic liver disease, so thinking about MASLD and MASH, and really saying that a lot of our patients with diabetes have this liver disease. And so how can we start to also impact this additional aspect of their care?
Great, thank you. Christie, I'm going to transition us over to heart failure, and was hoping you could kind of walk us through when you would start an SGLT2 inhibitor for heart failure with a reduced ejection fraction, and then kind of outline the differences for preserved ejection fraction.
Of course. So really, SGLT2 inhibitors now should be started right away for someone with heart failure reduced ejection fraction. So what you see here on this slide is the 4 pillars of heart failure. So the ACE, ARB, ARNI, and Entresto, which is a combination of sacubitril and valsartan, a beta blocker, aldosterone antagonist or MRA, and an SGLT2 inhibitor. So here what they recommend now in the heart failure guidelines is getting all 4 different medication classes on board, just because they have different mechanisms of action that can improve the heart function and reduce hospitalizations for heart failure. So it is recommended to get the SGLT2 inhibitor on board very early in the disease progression now. So as soon as they have that heart failure diagnosis, and that would be, I would even consider that for preserved ejection fraction as well. We've been putting it on earlier and earlier and not waiting until the heart failure progresses or until their first hospitalization for heart failure. And then also too, with reduced ejection fraction, I think there has been studies too that it's been beneficial to even start it at hospital discharge. So making sure they're hemodynamically stable, not dehydrated, so you don't precipitate euglycemic DKA. However, just making sure they're stable and they can take it, and it should be added on at the same time as like ACE, beta blocker, mineralocorticoid receptor antagonist to protect the heart. So for patients with heart failure preserved ejection fraction, we should be thinking about SGLT2 inhibitor therapy first. So as I mentioned previously with the DELIVER trial for dapagliflozin and the Emperor Preserve trial for empagliflozin, SGLT2 inhibitors have been shown to reduce cardiovascular death and hospitalizations for heart failure in the preserved ejection fraction population. So this is really starting to become the most robust data we have in this population. We know that historically, preserved ejection fraction patients do tend to accumulate a lot of fluid, have severe edema. So we always want to make sure we're titrating their loop diuretics. Recently, there's been some studies out with the nonsteroidal MRA finerenone, which has shown benefit in the heart failure preserved ejection fraction population as well. So that's another new tool, and finerenone is marketed as Kerendia. And then we also have been shown some modest benefit with sacubitril valsartan or Entresto. So we can consider that combination, sacubitril valsartan as well, especially beneficial in men with an ejection fraction less than 55 to 60, and in all women had better results with the sacubitril valsartan in that clinical trial.
Great, thank you. And I am going to transition us to this question that we've had multiple times from our subscribers. And that's, what's the role of combination therapy with a GLP-1 agonist with an SGLT2 inhibitor in patients? So, Lauren, would you want to tackle that one?
Absolutely. I use this all the time. So I feel like when you're first starting a patient, you think about what is their compelling indication. And so are you choosing the GLP agonist or the SGLT2 inhibitor? But ultimately, most of these patients are going to require additional pharmacotherapy, not just for their glycemic control, but when you start to think about all of the other benefits that we've already talked about today, right? The cardiovascular health, the kidney health, and the liver health, you start to say, why wouldn't I add this on? And so I'd say most of my patients, especially in my clinic, who have longstanding diabetes, and we know with that comes these cardiovascular and kidney disease, we're adding both of these on so they can get the most benefit from these medications. So I'd say, absolutely. I think where you start just depends on patient preference, tolerability, and really what their first initial compelling indication was. And again, thinking back to Stephen's comment about how far they are from goal would also help me determine, am I starting the SGLT2 inhibitor versus the GLP agonist first? And you can get into some really healthy debates with people about, personal preferences and where people choose to start. But I think ultimately it's just giving the patients their onus over their own health and where they feel comfortable with starting based on maybe what they've talked about with their family members, and really using them, but ultimately having that conversation of, here's where I'm starting you today, but this is what I'm thinking, down the line. We'll probably add this on at some point.
Excellent. Stephen, can you comment on the discussion you have with patients on combination therapy and what monitoring you ensure happens when patients are on both of these?
Oh, yeah, totally. And so I think just speak to some of our points where it's patients being on both of these. My typical communication to them is they all have a respective job. Some of them do some of these jobs better than others, like GLP-1s helping with weight loss. SGLT2s maybe helping with preservation of kidney function. But ultimately, hope is that these are working well together and hopefully synergistically to help control your blood sugars and hopefully live healthier, live longer, and hopefully prevent any of these cardiovascular events that we know are what are the main causes of morbidity and mortality for patients with diabetes. In terms of monitoring these therapies, specifically for things like GLP-1s, always keeping track of, I think weight is a big one. Just, a lot of patients are very surprised by how much weight they can lose these, but I do have a lot of patients too that, are sometimes disappointed by the amount of weight that they lose. Kind of ties into maybe some of the lifestyle changes that they also have to participate in with this. Monitor some of those sort of biliary symptoms that patients may experience, whether it's like biliary colic or potentially sort of gallbladder related issues, particularly in kind of our female population that are on it for long periods of time. For SGLT2 inhibitors, typically monitoring electrolytes, kidney function as well, making sure there's not sort of adverse electrolyte abnormalities or decline in kidney function that could occur because of that kind of persistent over-diuretic effect that these medicines may exacerbate. And then particularly for females as well, just talking about the frequency of maybe urinary tract symptoms. Are they having more frequent, more severe urinary tract infections, fungal infections, kind of those secondary side effects that these medicines can cause that can limit compliance and prevent them from wanting to kind of maintain these for a long period of time.
Thank you. And transitioning to risks, so you mentioned several of them. Lauren, are there other risks that you would warn patients about with SGLT2 inhibitors and GLP-1 agonists?
Yeah, so I think Stephen hit, the ones that we typically start with, the one when we think about their genital urinary infections. And really, I think that goes back to getting a good history with your patients too, to say what has been your history with yeast infections and just counseling on making sure, good genital hygiene, making sure, especially some of our older population, if they have any urinary, like inability to get to the bathroom on time and they have, wet underwear, saying like making sure you're changing out of any wet underwear or urinary pads. And then talking about, you can treat this over the counter, but also like letting them know that we're here for them if they needed to have a medication on board and saying, hey, there might be a point where there isn't, a line in the sand at which point we would stop your SGLT2 inhibitor, but we could have that conversation if it got to that point. The other thing I think about is euglycemic DKA. And so just making sure if our patients are getting sick, talking to them a little bit about their sick day management. And so if they're having any volume depletion, any vomiting or diarrhea, or if they have profound weight loss, so we typically think about as 3 kilograms in 2 days, making them understand that they should stop the medication until they're able to resume eating and drinking at their normal pace for at least 24 to 48 hours. And if there's anything that's happening that's causing them to not be able to keep fluids or food down for 72 hours, to give us a call so we can talk to them about their management of their SGLT2 inhibitor. And then thinking about, I think our inpatient team does a really good job of when patients are coming in for surgeries about when to stop these medications, but really making sure that when I see that a patient has an appointment scheduled, talking to them as well about when you would stop your SGLT2 inhibitor. So 3 to 4 days before any of those surgeries to prevent any of your kidney damage or potentially for these patients with the euglycemic DKA.
Great. And Christie, would you want to comment on risks with GLP-1 agonist use?
Yeah, so with GLP-1 receptor agonists, I think the big thing is obviously they do increase the risk of nausea, vomiting. So counseling people to eat smaller, more frequent meals so they don't have those unpleasant side effects. Stop eating when they feel full. Overall, in general, possibly considering a more low-fat diet to prevent some of that, because we don't want those GI adverse effects, one, to have them stop the drug because we know the cardiovascular kidney benefit that they have is great overall. So we want to do the best we can to counsel people to make sure that they tolerate it very well. Also recommending to rotate injection sites, preventing injection site reactions, proper counseling on how to administer the medication. And as far as warning and precautions, pancreatitis, we know that people that have had a history of pancreatitis are at higher risk for having it again. With the GLP-1 receptor agonist, we don't quite know what that risk is just because people with pancreatitis have been historically now removed from the trial as part of the exclusion criteria when we look at GLP-1 receptor agonists. So in general, it's a bit of a gray area whether or not to start it in someone with a history of pancreatitis. It would depend if we knew what the etiology of their pancreatitis was and how long it had been since they had an episode. Gallbladder disease. If they have a history of gallbladder disease, I do feel comfortable using it as long as it's not currently active gallbladder disease. We want to avoid using these agents in patients with a history of medullary thyroid carcinoma. And then also we have to be careful about pulmonary aspiration during anesthesia and sedation. So this is a question we get asked a lot is, should I be holding my GLP-1 receptor agonist prior to my colonoscopy, endoscopy, different procedure, which would require anesthesia?
Excellent. Thank you. Stephen, what are some barriers or hurdles to getting patients on GLP-1 agonists or SGLT2 inhibitors or the combo that you see in your practice?
I think some of the barriers, one barrier is just the GLP-1s, for the most part, come in injectable form. Yes, there's a sort of oral medication available, but in terms of the endpoints that we look for, and I don't believe there's the evidence out there to support that yet, although I feel optimistic that it hopefully will be. But some patients just have the needle phobia, and the injections for those medications may just be a significant barrier for them. I think the other two broad ones that we will see are cost and insurance coverage, depending on what a patient's payer source may be, can definitely influence the monthly cost. And a lot of patients, at least I take care of, just don't have the means to afford these medications if they are not covered under their insurance or part of some sort of charity prescription coverage. I think the other thing too is just availability of these medications. We oftentimes hear of shortages, suppliers shipping around, having to order online, having to use compounding pharmacies. And so I think just the economics of these medicines, just given they're in such high demand, has limited access for patients to take these. I mean, I have some patients that take them for maybe a month or two at a time and then go on a shortage and aren't getting it for about 6 months and then get back on it. So daily and weekly, monthly, annual use of it may be fluctuating depending on the patient as well. Those are kind of the main barriers that I'll see with patients. And there's other kind of those medical issues. Talked about some of the getting a good history, understanding your past medical history, some of the risk factors associated with medicines. If you talk with these patients about them, they may just be kind of like, hey, it sounds like a little bit too much for me. I already have, for the urinary tract infection, that's a big reason that several patients that I have won't want to take these medications. Polypharmacy is a big thing, I think, with some of these medications for patients that may be on a SGLT2, maybe on the ACE or an ARB, and their kidney function's just trending in the wrong direction while they're on these medications. So we have to decide which ones can be best for them to continue on if they can continue in tolerating them. And then there's also a lot of information online about what these medicines may be. I've had several patients that are worried about the formulated gangrene warning that may be on for SGLT2, some that are worried about the amputation risk that I believe has since been sort of disproven for SGLT2. So patients will come with their own kind of perceptions of what these medicines, the consequences, side effects of these may be. That is also potentially a limitation for why they may or may not want to use these.
Excellent overview. And Lauren, could you comment on the cost piece? What are some strategies you use to help get patients on these medications due to this higher cost?
Yeah. So, I think it's really looking at the formulary. And so, for a lot of the GLPs, when we started to have the shortage is when you really started to see insurance companies require the indication to clearly state that these patients had type 2 diabetes and really making sure that the agent prescribed matches up with the FDA approved indication. For me, it's been a little bit of trial and error, right? So sometimes it's like, okay, 1 year, one agent is approved on their formulary and the next year it's something else. And so trialing, different agents for those patients, sometimes we work through all the options that are approved for them and those patients have failed or really maxed out some of their benefit from a glycemic perspective. And so we have to, do a prior authorization to get them on something that may not be on formulary. I've really also utilized a lot of patient assistance programs for these patients. Unfortunately, some of those were paused when the supply dropped. And so a lot of patients, they weren't accepting new enrollments. And so that was really limiting for some patients to be able to get on these if they couldn't afford them. There's also copay assistance cards that can help patients who maybe have commercial insurance. But I think it's really just making sure you're utilizing your networks of your professional network, right? So whether it's your organizations you're a part of or, I'm familiar with Christie, so being able to text a friend and say, what are you all using, up where you are and how are you getting access to these? I think that's really beneficial and just talking with people about how they're getting them. There is some evidence out there about extending. And so I know the FDA doesn't, or the package inserts don't necessarily approve microdosing of some of these, but sometimes patients might be microdosing. And so there's some new evidence out there about still getting some benefit from microdosing of the GLP agonist to maybe extend it during times where patients might have an insurance loss or a lapse in insurance. For the SGLT2 inhibitors, I do think, again, really we have the cheaper option. So with dapagliflozin and being able to get that for patients, but that still comes at a pretty high cost, right? So some patients can really only afford a few dollars a month. And so when you're looking at even, $30 to $40 a month for a prescription and it's only one of them, that can still be a huge barrier. But understanding that maybe they don't have it on their insurance at all, and so they can get it through that. And so that's one option with the SGLT2 inhibitors. And then looking for some charitable pharmacies. So where I am, we do have some pharmacies that patients can go to if they've lost insurance. And so these pharmacies are getting medications through the manufacturers or through other donations, and they're able to get these patients these medications at a low cost or no cost. However, it does require often switching patients. So I might be switching patients from one SGLT2 inhibitor to another based on what they have in stock.
Great overview. Thank you.
We hope you enjoyed and gained practical insights from listening into this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit. Just log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses. On those websites, you'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools. If you're not yet a pharmacist letter, pharmacy technician's letter, or prescriber insight subscriber, find out more about our product offerings at trchealthcare.com. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app, or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.